Welcome everybody to tonight's Immunisation Coalition webinar on pneumococcal disease, a 2023 update. My name is Andrew Minton. I will be your moderator tonight. I work for the Immunisation Coalition and are responsible for our medical education activities, development and delivery to healthcare professionals. Before I start, I'd just like to say a few words that ties into tonight's webinar that gets us thinking about if a new pneumococcal vaccine or vaccines were to be added to the NIP, what impact may this have for healthcare professionals involved in immunization as part of the pneumococcal vaccination program. Pneumococcal disease recommendations are pretty clear for children, and rightly so, from infants through to toddlers, for children, for adolescents, through to adults and older adults, right through to more than 70 years old. There's a lot of focus on early immunization, again, as rightly so. Immunization for Aboriginal and Torres Strait Islanders and patients with underlying disease conditions, those patients with comorbidities, which could be several, 2 or more. But is there enough attention for adults over 70 years? And we have some slides on that already. So it'd be interesting to see if there are any questions around that at the end of the presentation. And also, have we vaccinated enough of those, either coming into the clinic or healthcare professionals, either GPs, practice nurses, going out to aged care centres. New 15 and 20 conjugate vaccines are now available. They're being reviewed by ATAGI. I'm not here to promote them at all. I'm just here to draw your attention to them and for possible inclusion in the NIP, and we wait for that. If these do become available, we hope that these new conjugates will, with additional serotypes, may help in both protecting more the community and providing a renewed stimulus for greater vaccination through our healthcare system, particularly for pneumococcal disease. Before we start tonight's webinar, I would like to pay a tribute to all Aboriginal and Torres Strait Islander peoples. In the spirit of reconciliation, the Immunisation Coalition acknowledges the traditional custodians of this country and their connections to land, sea, and community. We pay our respects to the elders, past, present, and future, and extend that respect to all Aboriginal and Torres Strait Islander peoples. I'm delighted to introduce tonight's speaker, Angela Newbound. She will be speaking, Angela will be speaking for about 35 to 40 minutes, and the remaining 15 minutes will be for Q&As. Please type in the questions within the Q&A box at the bottom of your screen, not the chat box, and then I will pick those up and read those out at the end of the presentation. Tonight's presentation will be recorded, so everybody will be on mute, and this presentation will be available on our website by about Wednesday of next week. So to introduce Angela, Angela Newbound is an immunisation education consultant based in South Australia and is a member of the Immunisation Coalition. She's been involved in immunisation program delivery in South Australia for over 20 years and provides clinical advice, support and education, not only in South Australia, but nationally to a wide range of immunisation providers. So without further delay, I'll hand over to Angela and take us through what's a very important and relevant topic of pneumococcal disease 2023 update. Thank you, Angela.
Thank you so much, Andrew, for that introduction, and thank you for the Coalition for inviting me to present this webinar tonight. I am proudly coming to you from Ghana country here in Adelaide. Very wet, woolly out there at the moment with thunder and lightning and quite a lot of rain. So hopefully I don't get a power blackout halfway through the presentation. So thank you very much for joining us this evening. And firstly, I would like you to join in and do a poll and just indicating whether you are a GP or medical practitioner, a nurse, midwife, immunisation nurse practitioner, a researcher or educator or a pharmacist or other. And we'll just let us know what our audience is tonight. Give you a few seconds to do that. We've got quite a few people on tonight, so hopefully we'll get a nice cross-section. How have we gone, Anastasia? We got a little bit of a... Oh, very good. So we've got 14% of GPs, medical practitioners, 77% nurses, midwives, immunisation practitioners. We've got 1% pharmacists and 8% others. So fantastic. That's great. So hopefully you'll find the webinar really informative. So we're going to go through these learning objectives tonight. I'm not going to karaoke the slide, but as per all learning activities, we've all got to put some objectives up there. And certainly Andrew's already drawn your attention to, the 15-valent PVCs and 20-valent vaccines as well. Okay, so fingers on your buttons once again. Can you identify the causative agent of pneumococcal disease? Is it A, Streptococcus pneumoniae, B, Staphylococcus pneumoniae? Is it C, Staphylococcus aureus, or D, Staphylococcus agalacti? That would be the word. All right. And I'm sure that you will do well with this question. How are those answers looking now, Anastasia? Let's have a look at the poll. Okay, so 82% of you said Streptococcus pneumoniae, 17% of you said Staphylococcus pneumoniae, and 1% of you said Staphylococcus aureus. Okay, right, well, the answer is certainly, in fact, a Streptococcus pneumoniae is responsible for causing pneumococcal disease. So we do know that this particular bacteria was first isolated by Pasteur in 1881. So it's been around for a very, very long time. It's a gram-positive, extracellular, opportunistic pathogen, really, that colonises those mucosal surfaces of the human upper respiratory tract. And in around about 27 up to 65% of children will carry S. pneumoniae. Around 10% of adults may well carry it as well. But it just has this really unusual relationship with the human host in the fact that it can be carried quite harmlessly, but it has that capacity to turn pathogenic and therefore cause quite significant illness in the host. We do know that they've got a surface that is composed of really complex polysaccharides, poly meaning many, saccharides meaning sugary proteins. So these types of organisms are really pathogenic to humans, and that polysaccharide coating of the bacteria helps it resist phagocytosis and is really the most important virulence factor of pneumococci. There's more than 95 capsular or antigenic serotypes, if you like, and each serotype elicits different type-specific immunity. We know that worldwide there's a small number of serotypes that cause most pneumococcal disease. The predominant serotypes will vary across age and across geographic area, and some serotypes cause more severe disease than others. We know that serotype 3 has often been referred to as the sugar-coated killer, because it behaves a little bit differently. It's got a very thick capsule, and it has just got these extended polysaccharide layers, which really favour nasopharyngeal carriage and resists antibody-mediated clearance. So it's got a high invasive capacity, causes severe infections such as complicated pneumonias and empyema with high mortality cases. And serotype 3 is a common cause of invasive disease in the adult population, accounting for around about 15% of all invasive pneumococcal disease cases in some reports. So we just really need to be very aware that these different serotypes have different propensities of causing asymptomatic colonisation, otitis media, meningitis, and pneumonia, for example. We do know that carriage is generally longer in children, maybe up to about 4 months, versus adults, which is around about 2 to 4 weeks. So there's a wide spectrum of illnesses that pneumococcal disease can cause, and we'll talk through a few of these as we go down the list, because we do know that they do manifest differently. And we do know that pneumococcal disease can be either invasive or non-invasive. Obviously, if it's non-invasive, the disease occurs outside of your major organs and outside of the blood. Otitis media, for example, which is a commonly caused by strep pneumoniae, detected in up to about 55% of middle ear aspirates from children with otitis media. So it's considered really the most commonest bacterial cause also. So this significant otitis media, of course, can cause significant morbidity in young children and cause permanent hearing loss. Definitely difficult to diagnose in that case, just because it's so complex to try and get a specimen from a child's middle ear. Obviously, pneumococcal pneumonia causes also significant morbidity and mortality, predominantly in the elderly and people who have got immune compromising conditions. And, you know, with a specific bacterial diagnosis confirmed in the cases also particularly associated bacteremia. So we're going to be talking about invasive pneumococcal disease because it is a lot more serious and life-threatening than the non-invasive pneumococcal disease. So we know that pneumococcal disease can be treated with antibiotics. However, we know that growing antibiotic resistance means that patients may be prescribed the whole combination of antibiotics. So we always say that prevention is much better than the cure. So definitely we've got to educate patients around pneumococcal disease. We've got to talk to them around pneumococcal vaccine recommendations. We need to sort of start setting a lot more reminders, perhaps in our practice management software. We need to search for patients who are at risk of invasive pneumococcal disease. So that means that they have a disease of some description that puts them in that higher risk category. So definitely we need to vaccinate more people. We know through some studies that we have suboptimal coverage in at-risk individuals. So invasive disease, so IPD, invasive pneumococcal disease, is defined really by the isolation of S. pneumoniae by culture or nucleic acid detection from normally sterile sites. So obviously blood, joint fluid, cerebrospinal fluid, etc. Earlier I mentioned pneumococcal disease, is often hard to diagnose. So there's a real thought process that it's probably really underrepresented. There's probably more cases than we actually do know about. But we use that baseline data that we do know about in order to monitor disease, hospitalisation rates, and certainly we've got the Australian Immunisation Register to monitor vaccination rates. Invasive pneumococcal disease commonly presents as septicemia, meningitis, and pneumonia. Septicemia and meningitis are more common in children, around about 70% of cases, with the exception of Aboriginal children who present more commonly with pneumonia. Most adults with invasive pneumococcal disease have pneumonia with bacteremia. Obviously, those less common clinical presentations, otitis externa, sinusitis, septic arthritis, endocarditis, pericarditis, etc. It is a notifiable disease in Australia, and it has been since 2001. The number of notifications actually fell quite dramatically after vaccines were introduced for infants some years ago. However, IPD rates remain higher amongst the youngest people in our community and the oldest Australians. Notification rates tend to remain reasonably consistent, but they are consistently higher in our Indigenous Australians than for other Australians. So it's really important that providers ask that question: do you identify as Aboriginal or Torres Strait Islander? And always follow that question up with the reason why you've asked it. Because if you do, then you are eligible for, pneumococcal vaccines either earlier, etc. Just letting them know that you're asking the question so we can better protect them from disease. You can see in 2020 we had lower rates of cases reported due to the COVID invasion. We had lots of strategies put in place, so there was no flu circulating. Flu is a common cause of going on to being an invasive pneumococcal disease as a pneumonia. So we did see less cases across those COVID years, but we've certainly been bouncing back to pre-COVID levels. Looking across 2022, this is sort of how cases looked across the country. So you can see they're very, very different depending on the state and territory that you live in. What does it look like across all of the years, including so far, or up to 21st of May in 2023? Definitely, we can see that it just bounces along. There's no real difference, not much difference between year to year. But we do know that viral respiratory infections predispose patients to bacterial infections, and that we see these co-infections have a worse outcome than the infections on their own. And you can see that little dip in 20 and 2021, just those two COVID pandemic years, just because of that mask wearing, the social isolation, etc. But if we're looking at 2023 so far, we're up to 536 notifications as of the 21st of May, so pretty recent data. If you're in the ACT, you've got 6 cases, New South Wales 148, Northern Territory 16, Queensland 107, South Australia 62, Tasmania 5 cases, Victoria 136, and Western Australia 56 cases. So once again, numbers are all over the place depending on the geographic region. So looking at the notifications regarding age, and this is the data obviously from the National Notifiable Disease Surveillance System, and clearly demonstrates that notifications are highest in the very young and in individuals. Once they reach 50 years of age, we can see those numbers really creeping up. So at the moment, we've got 430 notifications in children less than 9 years of age. You know, sort of across last year, and sort of about 990 notifications in people over 50 years of age. So something to be exceptionally mindful of. So who's at risk? There's a whole list of people who are at risk. You'll find this table in the handbook, you'll find it in the ATAGI advice, you'll find it on the National Centre for Immunisation Research and Surveillance website. So make sure that you've got a copy of it, make sure that you're aware of which of these conditions are eligible for NIP-funded vaccine, because a lot of these conditions are not eligible for NIP vaccine, which means the patient should be recommended to have the vaccine, but they will need a prescription and they'll need to purchase it. But just let's have a little look at some of those conditions that are not eligible for the NIP-funded vaccines. So we know that adults with chronic conditions such as diabetes and heart disease and lung disease, these are individuals that you would be seeing in your general practices quite often. They would be coming into their pharmacy, local pharmacy all the time, getting different medications, etc. And it's due to this, the chronic nature of these conditions, that, you know, individuals are really at risk of community-acquired pneumonia or CAP. As well as invasive pneumococcal disease all year round, not only during the winter, unlike, you know, seasonal influenza. Individuals with chronic obstructive pulmonary disease, asthma, or people who smoke, and those with chronic heart disease and diabetes have been shown to be at increased risk of pneumococcal disease compared to those with people without those types of risk factors. We know that people with these conditions and smoking can definitely affect patient outcomes, including short-term and long-term mortality rates. We know that it can, pneumonias can develop and certainly be leading to pneumococcal pneumonia. Community-acquired pneumonia, and in particular pneumococcal pneumonia, is, you know, really a significant economic burden, and especially using up a lot of hospital beds, and has a big impact on a patient's quality of life as well. So we definitely need to be talking to these individuals about that strong recommendation of getting this vaccine or these vaccines, even if they're not eligible to receive them funded. Diabetes has the greatest impact on the risk of invasive pneumococcal disease, as well as community-acquired pneumonia in individuals less than 64 years, and especially in individuals less than 40 years of age, with or without other comorbidities. There was a Danish study that looked at these individuals less than 40 years, and they were found to have a 3-fold higher rate of hospitalisation due to pneumonia than individuals without diabetes of a similar age. So it's really been suggested that the increased risk of pneumococcal infection in patients with diabetes really results from the harmful effects of hyperglycemia on the immune system, as well as on the pulmonary function. And due to this ongoing subclinical inflammation, these patients really are at risk of developing this, cardiovascular disease as well. So providers, once again, need to talk to these patients and explain those risks. Obviously, the recommendations are in the handbook. You will also find recommendations around the management of diabetes in the RACGP handbook for practice. So your chronic heart failure or heart disease patients, and so that includes your congestive heart failures and cardiovascular and valve disease, once again, about a 3.3-fold increased risk of community-acquired pneumonia and up to about 9.9-fold risk of invasive pneumococcal disease when you're comparing them to patients that don't have those risk conditions. So there was a hospital-based epidemiological study of invasive pneumococcal disease in adults in Belgium that really demonstrated a significantly higher case fatality rate during hospitalisation. So once again, not a funded vaccine for these groups, but definitely highly recommended. Once again, the recommendation is in the handbook, but also through the National Heart Foundation of Australia. So those with chronic obstructive pulmonary disease, chronic bronchitis and or severe asthma, which we'll talk about, once again, higher risk of CAP as well as IPD than individuals without these comorbidities. So looking at around about anything from a 1.3 to a 13.5-fold increased risk for community-acquired pneumonia, 1.3 up to about a 16.8 risk for invasive pneumococcal disease. Having COPD often means the use of inhaled corticosteroids. This, in addition to increasing age, lack of pneumococcal vaccination, definitely has been identified as an independent factor for recurrent community-acquired pneumonias in adults. So these patients really have reduced innate defence mechanisms in the airways. They've got ongoing subclinical inflammation as well following recovery from pneumonia. That's certainly been reported in some studies. So severe asthma is really defined as requiring hospitalisation or hospital visits or the use of multiple medications in order to manage their asthma. Once again, pneumococcal vaccines aren't funded for these individuals on the NIP. We know that asthma is a chronic inflammatory disease. We know that it's characterised really by airway hyper-responsiveness, airway inflammation, reversible airflow obstruction and airway wall remodelling. The respiratory epithelium is really that first line of defence against inhaled pathogenic agents. And so we know that in asthmatic patients, they've got this abnormal airway morphology. So this is probably why these patients are at increased risk of IPD. We know that individuals with asthma tend to have this increased sputum production and that increased airway obstruction, really, that just makes it difficult for them to effectively clear the airway. And because of that impaired clearance, it just is a lovely environment for invasive bacterial infection. So with your cigarette smokers, if they are currently smokers, then please, please, please talk to them about the benefits of ceasing smoking. This is one of the strongest independent risk factors for invasive pneumococcal disease. So they've got a high risk even if they were an ex-smoker, but we can definitely say give up smoking because there's lots of benefits. There was a study in Australia in 2011 that where smokers were shown to be sort of 3.7 times more likely to develop pneumococcal bacteremic pneumonia than non-smokers. So for their own health and to decrease this risk, give up smoking for sure. So there's been a little bit of a history, hasn't there, with pneumococcal vaccines coming onto the NIP. So lots of changes over many, many years. And there has been recent changes with the arrival of the 2 extended valency vaccines, being the 20-valent pneumococcal conjugate vaccine, Prevnar 20, and the 15-valent pneumococcal conjugate vaccine, which is called Vaxneuvance. Obviously, these vaccines are now available on the private market. They are not on the NIP at this time. And there's an interim recommendation for their use in the immunisation handbook. We've not seen a target advice at this stage, but I'm sure that that will come in time. So as Andrew said, these vaccines potentially pending for the NIP. So how would you feel if they ended up on your NIP as well? But we will have to wait and see if there'll be a bit of an overhaul to the pneumococcal vaccination program over time. Okay, hands on buzzers once again. So we're going to ask the question around the vaccines. What is the difference between a Prevnar 13 and a Pneumovax 23? So A, Prevnar 13 is a 13-strain polysaccharide vaccine, and Pneumovax 23 is a 23-strain conjugate vaccine. Or is it B, Prevnar 13 is a 13-strain conjugate vaccine, Pneumovax 23 is a 23-strain polysaccharide vaccine? Or C, they are both conjugate vaccines but contain a different number of strains? Or D, they are both polysaccharide vaccines but contain a different number of strains? So we'll give you a few seconds and see how you go with this poll. Okay, how are we looking, Anastasia? Okay, we've got a little bit of a mixture. We've got 15% think it's A, 51% think it's B, 26% think it's C, and 8% think it's D. Okay, the answer is B. It is Prevnar 13 is a 13-strain conjugate vaccine, and Pneumovax 23 is a 23-strain polysaccharide vaccine. So, just to ensure that our new providers are aware of what a conjugate vaccine means. So a conjugate vaccine is a type of bacterial vaccine that's made by chemically linking to a conjugate or to a protein. So that chemical linking is conjugating the vaccine. So what they've done is they've taken a tiny piece of that polysaccharide coating from around the outer surface of the bacteria, and they have chemically bound it to a carrier protein. This improves the immune response to the vaccine, particularly in young babies. We've got a couple of these conjugate vaccines in our schedule, one of them being the Hib vaccine, so your Haemophilus influenzae type B vaccine, your meningococcal ACWY vaccine, as well as these pneumococcal conjugate vaccines. So with those polysaccharide vaccines, so your Pneumovax 23, they do not elicit a strong T cell response. So by binding the polysaccharide to a carrier protein has demonstrated that we get a really good T cell dependent process, and therefore we get a good antibody response. So Prevnar 13, for example, the polysaccharide off the surface of the bacteria, chemically linked to a carrier protein, and in this case, it's a non-toxic diphtheria CRM197 protein. It's funded as part of the infant program. It's given at 2 months of age or as early as 6 weeks, again at 4 months and again at 12 months of age. But for Queensland, South Australia, Northern Territory and Western Australia, our lovely little Indigenous bubbies get an extra dose at 6 months of age that's funded under the NIP. Also, any children with certain medical conditions, putting them at risk of pneumococcal disease, are eligible for that extra dose of vaccine at 6 months of age as well. So if any little babies have missed their scheduled doses, please use the right catch-up plan for them, because in the handbook you'll see that there's 2 different catch-up plans. So make sure you're using the right version. So a single dose is also listed on the NIP for Aboriginal and Torres Strait Islander people at 50 years of age and over, if they have no risk conditions. Non-Aboriginal and Torres Strait Islander people at 70 years of age and over with no risk conditions. All individuals with certain risk conditions can have funded NIP vaccine, but you might have individuals with certain risk conditions where they don't get funded NIP vaccine. Obviously, still 3 doses are recommended for any of your patients that have had a hematopoietic stem cell transplant. If you've had anybody that's 70 years of age that have come in, absolutely, they do a 13-valent vaccine. If you've got anyone older than 70 that has never received a 13-valent pneumococcal conjugate vaccine, please give them a dose and record it on the AIR, and it is a funded dose. So please go ahead. Hands on buzzers again for our next poll. So can Prevnar 13 be given concurrently with Zostavax and influenza vaccines? A, no, the combination should be avoided. Or is it B, Prevnar 13 can be given with Zostavax, but not with influenza vaccines? Or is it C, Prevnar 13 can be given with influenza vaccine, but not with Zostavax vaccine? Or is it D, Prevnar 13 can be given with influenza and Zostavax vaccines? So we'll give you a few more seconds to get your answers in. Okay, Anastasia, how are we looking? Okay, 2% said no, we should be avoiding it. 1% said it can be given with Zostavax, but not influenza. 29% said it can be given with the flu vaccine, but not with Zostavax. And 68% said yes, it can be given with both influenza and Zostavax. And that is the correct answer. So answer D. All right, so yes, you can co-administer Prevnar 13 with flu and Zostavax vaccines according to the Immunisation Handbook. Okay, so at this time with the 13-valent pneumococcal conjugate vaccine, there is not a recommendation for revaccination. It is a single dose only outside of the childhood program, apart from the 3 doses recommended for your hematopoietic stem cell transplant patients. It is slightly more reactogenic and it does tend to sting a lot. Those of you that have been vaccinating the babies will know that because they just scream that little bit louder. But look, mostly it's a well-tolerated vaccine, particularly, with the adults as well. With your 23-valent vaccine, so once again, this is just a polysaccharide vaccine. There's no conjugation onto a carrier protein. So they've just used that polysaccharide coating around the outer surface of the bacteria. So we know that polysaccharide vaccines do stimulate a B cell response. However, they don't involve the T helper cells. So there's not a T cell response, and therefore they don't result in a lasting immunity. And they have an inadequate antibody response in those infants and young children who are in that highest risk group of acquiring pneumococcal disease. So they're the ones we definitely want to be able to protect. So obviously that's why they get the conjugate vaccine. And so definitely we know that Prevnar 13 is in the children's program, but certainly we are using 23-valent polysaccharide vaccine as well in certain individuals, definitely those with some medical risk factors, they'll get it for free, others they won't. But definitely for our Aboriginal and Torres Strait Islanders in those particular states, South Australia, Western Australia, Queensland, Northern Territory, then they get that, little bubs will get that extra dose at 6 months, but they also get 23-valent vaccine at 4 years of age, as well as a second dose 5 years later. So it can be administered either subcutaneously or intramuscularly. However, whenever we are given an option, we would always go, the preferred route is intramuscular. There are less localised injection site reactions. Always check the Australian Immunisation Register, the AIR, prior to administering any vaccine. But, and you know, definitely with the pneumococcal vaccines, to really ensure that your minimum intervals are met between the doses, and that the number of doses doesn't exceed what is recommended. And for your 23-valent pneumococcal polysaccharide vaccine, the PPV, is now limited to 2 doses. But just always remember that if there is no written record of anybody receiving any pneumococcal vaccine, we then assume that they have not had it and we start again. We would rather give them a bit more of a sore arm than leave them unvaccinated and at risk of pneumococcal disease. So the National Immunisation Program, 2 doses, 23-valent pneumococcal polysaccharide vaccine, listed on the NIP, obviously for Aboriginal and Torres Strait Islander people at 50 years of age and above. Those individuals with certain medical conditions may be funded, may not be funded. Any children at 4 years of age that have got those associated risk conditions as well. And like I said, Aboriginal and Torres Strait Islander children in South Australia, Western Australia, Queensland, Northern Territory at 4 years of age. Please put a recall on, because when they due that next dose at 9 years of age, then it's not a scheduling point for anything and it can easily be missed. Just remember, these vaccines are not on the PBS, so you can't write a PBS script for them. People will need to pay full price for them. Just remember, people with private health insurance, talk to their health insurance companies and see what type of a rebate that they may get back from purchasing the vaccine. Okay, and our final poll, fingers on the buttons. Your patient is 45 years of age and diagnosed with a hematological malignancy. What is the current recommended pneumococcal vaccination schedule for this patient? A, Prevnar 13 first, followed by 2 doses of Pneumovax 23. Or B, Prevnar 13 first, followed by 1 dose of Pneumovax 23. C, Pneumovax 23 first, followed by 1 dose of Prevnar 13, or D, Pneumovax 23 first, followed by 2 doses of Prevnar 13. Let's see how you go. A couple of seconds. Okay. How are our answers looking now? And so, all right, okay. So 58% of you chose A, that Prevnar 13 should be given first, followed by the 2 doses of Pneumovax 23. 18% 13 first with 1 dose of Pneumovax 23. 9% said Pneumovax 23 first with 1 dose of Prevnar, and 15% Pneumovax first with 2 doses of Prevnar. So the correct answer is A. So Prevnar 13 first, followed by 2 doses of Pneumovax 23. Always remember to observe the minimum intervals between these vaccines. So it's 12 months between when you give the Prevnar 13 to when you give Pneumovax 23. However, an interval of 2 months is acceptable. And between those 2 doses of Pneumovax 23, it is a 5-year interval. If a patient has already received a dose of Pneumovax 23 and you are now administering a Prevnar 13, then there must be a 12-month minimum interval between that Pneumovax 23 and the Prevnar 13 dose. Okay, so here we go with the changes. All right, so we've got some new vaccines. One of them is called Vaxneuvance. It is a 15-valent pneumococcal conjugate vaccine. It is TGA registered for adults and children from 6 weeks of age. Obviously, multi-dose regime for the children and a single dose for adults 18 years and over at the moment, as it is written in the interim recommendation in the Immunisation Handbook. You'll see there's additional serotypes there, but certainly does show that it is comparable with the Prevnar 13 that we have currently. Once again, conjugated vaccine to that CRM 197 protein. In regards to the additional serotypes, I suppose, it does include serotype 3, of course, which continues to be a really significant cause of invasive disease in children. Approximately 80% of all adult invasive pneumococcal burden is among adults 50 years and over, which we saw before. Serotypes 3, 22F and 33F certainly contribute significantly to the burden of invasive pneumococcal disease. So we will wait and see what happens in regards to NIP listing or not, but currently private prescription only. We also have a Prevnar 13, so this is a 20-valent pneumococcal conjugate vaccine. There's the serotypes there, TGA registered for adults 18 years and above as a single dose. Wait and see what happens, but definitely another conjugated vaccine using the diphtheria protein and CRM 197. So changes may be afoot just to keep you on your toes. Look, vaccine coverage. It's not as good as what we want it to be. I know that you are just so fatigued. You're asked to do so much, but nobody's given you extra days in the week or as in the day. But just have a little think about what strategies that you could employ, perhaps in your practice, to sort of raise awareness of pneumococcal disease and raise awareness of pneumococcal vaccines. And whether or not you can kind of meet as a team in your practice, find a week, maybe twice a year, to do a really targeted campaign, either do really heavy recall campaign with the patients that you have already in your software system, or maybe just target specific medical conditions. So just do a big blitz on your diabetic patients, or a big blitz on your smokers, or your patients with malignancies, whatever you choose to do. But we just hope that it's a conversation that you will constantly be having with individuals that have got these medical risk factors. So increasing coverage certainly has been a challenge, but what we do know is uptake is better when there is a healthcare professional recommendation. So if you recommend it to your patients, let them know that they've got a disease that gives them a higher risk of invasive pneumococcal disease. Let them know what their vaccine choices are. Patients don't know what they should have. They don't know what they've had previously. So we just need to use our voice. We need to use our recall systems. And certainly the tool that's going to hopefully bring great joy to your life is the PneumoSmart vaccination tool. So the tool's been created using the pneumococcal vaccination recommendations in the Australian Immunisation Handbook. It's developed to assist GPs and specialists and other immunisation providers really to understand the recommendations and comply with those recommendations. Pneumococcal vaccination, as we know, exceptionally challenging, but the tool, we have kept it up to date, and we have added in those 2 higher valency vaccines as choices to be offered to your patients. So the tool provides guidance on pneumococcal vaccinations for children less than 5 years of age. However, it does not calculate catch-up pneumococcal immunisations for children less than 5 years of age. So please use the tools in the Immunisation Handbook or the Immunisation Calculator for doing that. But the tool will also guide you on which pneumococcal vaccines not only are recommended for patients, but are also either NIP or self-funded. Once again, remember, if there is no written record, get the patient to try and find their written records, either in a previous general practice or whatever. But if the patient can't produce any, there's nothing seen on the AIR, then we would proceed as though the patient has never received previous pneumococcal vaccines. So you'll find the tool on the Immunisation Coalition website. If you just go to your search engine, whether it's Google or whatever you use, and just type in PneumoSmart, it will take you directly to where you go. It's just easy to use. It's a tool that really can help you navigate this complex vaccine recommendations. Once again, like I said, it will guide you to which vaccines are funded, or whether the patient is going to have to purchase them via a prescription. Definitely, we want you to give us feedback on the tool. We'd love to hear from you. So when you put patients in, just always remember to tick that box, I've read and agree to the terms and conditions, and then you proceed through the tool, and at the end, when it'll give you a vaccine summary of what to give and when to give it, and there is a feedback button there. So we would really love to hear your feedback. So just conclusions, we do know that pneumococcal disease is just a bad disease. It causes morbidity, it causes mortality. We do know that, young children, our elderly, Aboriginal Torres Strait Islander individuals, people with certain risk factors certainly have higher risks of invasive pneumococcal disease. Definitely look at those recommendations. for those people that are at risk, searching your practice management software, using the PneumoSmart tool, just being aware that those higher valent vaccines are now approved. They are available on the private market. So anybody that has a medical condition that does not allow them to have access to an NIP-funded vaccine, then you would be needing to write a prescription anyway, whether you write it for 13-valent, 15-valent, 20-valent, you've got options there as well. But remember, there are lots of resources, the target advice, NCRS fact sheets, and of course your immunisation handbook to help guide you as well. So definitely there's product information sheets for Pneumovax 23, as well as your Prevnar 13, as well as for your 15-valent Vaxneuvance or your 20-valent Prevnar 20 vaccines. So I'd just like to really thank you very much for listening. I know I've spoken at 1,000 miles an hour, but hopefully I've kind of made sense for you. And I hope you found it really helpful and informative. So happy for any questions if there are any in the box. Thank you.
Thanks very much, Angela. That was a really fantastic talk. So you covered a lot of different areas. So we do have a number of questions. We will be going past the 7 o'clock finish time. For those that wish to drop off at 7 o'clock, that's fine. But it's important that we get through some of these questions. So there's 8 questions. So I'll just read them out in no particular order. Why are infants and children under 4 years still getting pneumonia if they are getting vaccinated, or are they unvaccinated? Is the vaccine not effective enough?
Yes, well, we certainly do know that some children do get pneumonias before they've had all of their vaccine programs, so they may be partially vaccinated. We do have a small number of children in our communities that are not vaccinated. And certainly, you know, children that are getting pneumonias, it may well be, in this case with the grafts, they are invasive pneumococcal disease. It's been determined. That's why the report is there. But we've also got to remember that not all of our vaccines, hardly any of our vaccines are 100% effective in 100% of people that we give them to. So people can still get disease even though they are fully vaccinated, but the vaccine, you know, the immunity that we get from vaccines does help us not get as unwell with complications than if we were not vaccinated. So it's one of those things, unfortunately, and we don't have the holy grail of perfect vaccines.
Yeah, I looked at the graph from 2022 that you presented. So there were about 1,900 notifiable cases for IDP. And just doing a quick calculation, 20% of those were for the under 5, but 40% were for the over 65s. But of course, there's more adults than there are children. But it just sort of, yeah, they still get IDP, but we must not forget the older adults as specific, especially since they have underlying diseases and other risk conditions. So their outcome might be poorer than that of children. So
and we also know, Andrew, that anybody can get pneumococcal disease. Anybody can. So they might not have an identified risk factor. So no one's ever talked to them about, you know, pneumococcal vaccines before because they're not recommended to have them if they're healthy. So yeah, there'll be some of those cases as well.
Another question here: what is the reason to give Pneumovax after Prevnar? Why not another Prevnar?
Yeah, look, you know, it's interesting that, you know, they go on whatever the data is that they've got available to inform these decisions. So at the moment, it's a good idea to give that Pneumovax 23 after your Prevnar 13 because, of course, you're covering more serotypes with the 23-valent. So that is the current recommendation. Obviously, we've got these higher valency conjugate vaccines. Will they replace the 23-valent polysaccharide? We don't know that yet. That will be, people that are, much more intelligent around pneumococcal disease than what I am to make that decision. But it covers them for more disease. Giving Prevnar 13 or the conjugate vaccine first is going to have a much better immune response. And we're hoping then with the pneumococcal, the Pneumovax 23s, then we'll get reasonable, antibody uptake as well.
Another question here from Tanya. Should you routinely vaccinate all non-Indigenous patients with Prevnar 13 every 5 years over the age of 70?
Not every 5 years. Certainly, if they are a healthy individual, they just get the 1 dose of Prevnar 13. That's it. If they're non-Indigenous, if they are Aboriginal or Torres Strait Islander, then that's 1 dose of Prevnar 13 at 50 years of age, followed by the 2 doses of Pneumovax 23. But there's just no recommendation at the moment to give more than that 1 dose of conjugate vaccine.
One from Sally here. Is there a reason for why there is such a large difference in the minimum interval between this would be Prevnar 13 and Pneumovax 23? In brackets 2 to 12 months.
Yeah, look, once again, the decisions like that are really informed by what the data shows. So that's all they can really go by is, what are the, what's all the clinical evidence for in trials, etc. And certainly making sure that that 13-valent is going to prime that immune response, really, really well. But, we can bring on that 23-valent within a 2-month gap. The other way round, we definitely certainly want to not impact on the polysaccharide 23-valent previously given. That's why they'd wait the 12 months before a Prevnar 13.
Thank you. There's one from Julie here. Anecdotally, we have found that Prevnar 13 given at the same time as Shingrix, so I think we don't give it with the Zostavax, tends to result in significant side effects. Can you please comment?
Yeah, look, both of them are reactogenic vaccines. I think that's important to note anyway. So, and I think it depends on what people call significant side effects, etc. You might have a red swollen arm. Does it go away after 4 or 5 days? Then it's not really a significant adverse event. It's something that we would be expecting to see. Obviously, wherever you can, use opposite limbs. That's not always possible when you're giving, lots of vaccines, but they are both reactogenic vaccines. So we would definitely be letting our patients know about those injection site reactions. Anything that where there's redness and swelling that involves the joint above the injection site or the joint below the injection site, that is a reportable adverse event. But if the joints are not involved, it could be just an extensive limb swelling that's not reportable.
I think we've got an opportunity to discuss with patients whether they come into the practice or whether or not the practice goes out to an aged care facility. Since we're giving influenza, we're in the influenza season, we should also be talking about pneumococcal vaccination because
absolutely
that's at the same time.
Yeah, absolutely.
Yeah, okay. And what about COVID? Can we give pneumococcal vaccination with COVID on a different arm? I couldn't see any information about that.
Yeah, look, the advice is that there's just not enough data. And so they suggest that if it's possible, separate by 7 days. However, if you need to give them to be opportunistic and make sure that you get people vaccinated, they can be given on the same day. But there's just no real data around it to support one way or the other. So it depends on whether your people, your patient is a flight risk or not, or whether you want to nail them while they're in your practice. But that would be the advice.
Just a couple of more questions, again, for those that want to drop off at 7, but I will continue just for another minute or so. Do well-controlled asthmatics have increased risk of IDP, or is it simply because their asthma is poorly controlled?
No, asthmatics, full stop, have increased risk, but certainly asthmatics with severe disease, where they're on multiple medications, etc., they've probably got quite significantly poor lung clearance, then they would be at higher risk than just someone with asthma. So if they've got severe asthma, higher risk.
Last question here. This would seem an obvious one, but does vaccination prevent infection in the kind of a nose and the ear, or is it really just more for severe infection?
Yeah, look, that's a really good question. Does it, reduce carriage rates? Certainly, there is a little bit of data around that with that reduction of carriage, but it certainly is to obviously prevent severe disease. If anybody was to contract pneumococcal disease, it's to prevent severe disease.
Okay, I think we'll end it there. We're 5 past the hour, so there'll be a short survey coming straight after this event, or you might already have it already. We look forward to getting your feedback on that as we continue to improve our webinars. And if you want to provide any sort of information about topics that we might cover, then we'd also welcome that feedback as well. Just a bit of a plug for a couple of events that are coming up. You can register for the Adult Immunisation Forum on the 22nd of June. So if you go to our website, www.immunisationcoalition.org.au, this is a hybrid event. It's free. So you could register online. It's probably a bit short notice to get over to Perth now. And also the information hasn't gone out yet, but there's going to be a 2-hour Professor Alan Cripps pneumococcal disease webinar. It's a memorial webinar on the 10th of August. So that will consist of about 20 minutes of slides about highlights and achievements from him over the last 20 or 30 years. And then we go straight into panel discussions and leave 30 minutes at the end for Q&As. That's it from me. Thank you, Angela, again. Thank you for the audience for staying as long as you have. Thank you for your questions. I hope it was of value to you. I'll see you again in August. In fact, will be our next webinar on RSV. So with that, I'll say good evening, stay safe, and see you next time. Thank you.
Good evening, everyone. Bye.